Welcome all for the today's session. So today's topic is about ultrasound in obstetrics. Very frequently asked high topic in obstetrics. Okay, sometimes you can have a short note on this. Your question may say ultrasound in obstetrics, ultrasound in first trimester, ultrasound in obstetrics and gynecology. Please read the question. Suppose you have read this particular topic of ultrasound in obstetrics and your question is ultrasound in obstetrics and gynecology. Don't forget write the role of ultrasound in gynecology. Because you have prepared the short note of obstetrics, you will write complete about obstetrics. No, you should write whatever is been asked. Okay, so today we'll discuss about ultrasound in obstetrics. So what exactly the ultrasound is? The ultrasound uses sound waves with frequency more than 2 megahertz. What is sonar? Sonar is a sound navigation and ranging. Okay, clinical obstetric ultrasound is introduced by the Ian Donald from Glasgow in 1958. What are the principles of ultrasound? It is based on the piezoelectric effect. So synthetic photoelectric crystals are present in the transducer, which will convert electrical energy into sound waves. These sound waves will strike to the tissue, will get reflected from the tissues, and this reflected ultrasound will further get converted into electrical signals, which will give you the image. The speed of ultrasound in the soft tissue is 1540 meters per second. Frequency of the ultrasound for abdominal probes, it is 3 to 5 megahertz. For TVS, it is 5 to 7 megahertz. You should remember these frequencies. Okay. So what is the importance of the frequency? You use more frequency, you get better resolution. But more the frequency, there is a less tissue penetration, so greater attenuation. So TVS will have high resolution, but poor tissue penetration. Okay. So factors affecting the echo strength. What are the factors which will affect the echo strength? So acoustic impedance mismatch. That means whenever there is a interface, say for example, bone tissue interface, that will give you the maximum reflection. Okay. Then another factor affecting the echo strength is the angle of incidence. If your beam is perpendicular to the surface, then there will be maximum echogenicity. Okay, and then strength of the ultrasound beam and size of the reflector. So these are the factors affecting the echo strength. Okay, so golden rule is that more reflected ultrasound, stronger is the echo and brighter or the hyper echoic image. Okay, so you should describe the modes of the ultrasound. So B mode is the brightness mode, which is used for two-dimensional image for routine obstetric scan. Then you have M mode for moving structures. It is used for fetal cardiac activity. Then you have Doppler ultrasound, which is based on the Doppler frequency shift. It detects the blood flow velocity and the direction. Okay, it produces flow velocity waveform, that is FVW, flow velocity waveform. Okay, then you have three-dimensional ultrasound, produces lifelike fetal images, then volume data stored and reconstructed. This is a very important concept because normally what happens when you do the 2D ultrasound, you scan the patient, take the image, but if you want to see that particular plane again, you will have to call the patient again. But in 3D, there is a volume data storage. Okay, so the image is stored in that particular 3D format. Okay, and you can see it later on without presence of the patient. Okay, you can study it once again. Okay, in any plane. So that is what is the advantage with the 3D ultrasound, that is the volume data stored and reconstructed. Okay, so what are the advantages of 3D ultrasound? Better visualization of the complex anomalies, stored volume reviewed later. You can store the volume and review it later. Improved prenatal diagnosis, better parental bonding, and useful teaching too. Okay, so common uses for fetal face, cleft lip, cleft palate, for brain, corpus callosum, cerebellar vermis, congenital heart defects. These are very well seen on the 3D ultrasound. Then what is the safety of ultrasound? That also you should mention. So tissue effects. Normally there is a temperature rise, microbubble formation, and cavitation. There are important facts about safety. There is no proven harmful effect that you should highlight. Use only for valid medical indications. So it should be used only for valid medical indications. Keep examination duration as short as possible. Doppler will require higher power output. Okay, so safe upper limit is a 1000 milliwatt per meter square. Then indications of ultrasound, everyone knows well. I'm just going to enumerate. It may be fetal indication, it may be maternal indication, or it may be fetal placental indication, what we can say, or interventional indications are there. So fetal indications, diagnosis of pregnancy, gestational age dating, multiple pregnancy, fetal cardiac activity and viability, detection of congenital anomalies, fetal growth assessment, that is IUGR, biophysical profile, presentation, ectopic pregnancy. These are fetal indications. Then uteroplacental indications like placental localization, previa placenta, abruptio placentae, molar pregnancy, uterine malformations, Liker assessment, cervical incompetence, chorionicity in twins. Then maternal and procedural indications such as pelvic mass evaluation or guidance during obstetric procedures. Then amniocentesis, choriovenous sampling, chordocentesis, fetoscopy, intrauterine fetal therapy, external cephalic version. So these are the indications you should mention. You should divide them and always write either in boxes or giving the subheadings. Okay. Then first trimester ultrasonography. If you are asked the short note on first trimester ultrasonography, you will first describe about little bit about the principles of ultrasonography. Then you will directly go on the first trimester ultrasound. Remember, your findings should be or text should be related to the first trimester ultrasound only. So what are the uses in the first trimester? Confirmation of the intrauterine pregnancy, confirmation of viability, dating of pregnancy, diagnosis of ectopic, diagnosis of molar pregnancy, diagnosis of multiple pregnancy, and early fetal anomaly. You can take the screenshot or you can take the photo of this. Normally on TVS, when do you see the gestational sac? When beta HCG level is around 1000 to 1200, you will see the gestational sac. With transabdominal gestational sac is seen around 6000 milli-international unit per ml beta HCG level. Yolk sac around 7000 milli-international unit per ml. Embryo will be seen when the beta HCG level is around 11,000 milli-international unit per ml. Okay. Now we are talking about the first trimester ultrasound. Okay. Then normal gestational sac and the pseudo gestational sac. You should be able to differentiate between the two. Okay, so how does normal gestational sac look like? It is eccentrically located. Double decidual sac sign is there. Yolk sac and fetal pole will confirm that it is an intrauterine pregnancy, and growth is around 1 millimeter per day. While pseudogestational sac will be centrally located. Okay, there will be irregular outline. There is no double decidual sign, and it will be an empty sac. Okay, so TVS findings by gestational age, by 4 weeks, you'll be able to see the choriodecidual thickening. By 5 weeks, gestational sac plus yolk sac plus embryo. At 6 weeks, cardiac activity. At 7 weeks, remember, lower limb buds will see by around 7 weeks. 8 weeks, you will see the upper limb buds. 9 weeks, you will see the spine and the choroid plexus. So we are describing the first trimester, and week-wise we are going. So we are restricting ourselves to the ultrasound in the first trimester. Okay. Another concept which we need to know in the first trimester is a pregnancy dating. Then best parameter in the first trimester will be CRL. Okay. That is the gold standard. Accuracy is plus minus 2.1 days. And after the first trimester, which parameter is used for dating? Various parameters are used like a BPD, that is biparietal diameter, head circumference, abdominal circumference, femur length. Okay. Between 14 to 28 weeks, transcerebral diameter or TCD is more accurate. Okay. The CRL. You can calculate certain formulas. Also, you should know how to calculate the gestational age in days. CRL in millimeter plus 42 will be the gestational age. Okay. If you are measuring the mean sac diameter, it is the mean sac diameter plus 30 will give you the gestational age in days. Okay. Then you should also know ultrasound markers in the first trimester. Nuchal translucency normal level is up to 3 millimeter. It is increase associated with the trisomy 21, trisomy 18, trisomy 13, Turner syndrome, triploidy. So you should mention the importance of the nuchal translucency normal accepted level. That also you should be able to mention. Then come to the ectopic pregnancy. TVS will be able to detect around 90% of the tubal ectopic pregnancy. You will be able to see empty uterus, pseudogestational sac may be seen, ecogenic fluid in the pouch of Douglas, and ring of fire appearance on the color Doppler. Okay. Then come to the mid-trimester ultrasonography, that is around 18 to 22 weeks, where we are going to do the head-to-toe examination of the baby. Okay. So what is the importance of the benefits? It will confirm the viability, dating also you can do, detect the anomalies, multiple pregnancy, placental localization, baseline fetal biometry, high-risk pregnancy surveillance, guidance for invasive procedures. That is what is the importance of this mid-trimester ultrasonography. Okay, so don't only think that it is only anomaly scan. Even the cervical length is going to be very, very important in this particular period. Okay. Now coming to the gestational age assessment. Okay, so gestational age between 14 to 20 weeks. Again, the parameters: biparietal diameter, head circumference, abdominal circumference, femur length, etc. Okay. Now, when you take this head circumference and biparietal diameter, which plane is used? Normally, we use which plane? It is the thalamic plane which is used. Okay, so these are the features of the plane which we are going to use. So you should be able to see the midline falx, you should be able to see the cavum septi pellucidum, you should be able to see the thalami, and it should be symmetrical in nature, and cerebellum should not be seen. Okay, so if we are getting cerebellum, then it is not appropriate plane. Okay, so midline falx, if you can see, that will confirm that it is a true axial section. Cavum septi pellucidum will tell you that the landmark for correct level it is there. Then thalami is the central landmark, and if you can see the skull as a symmetrical structure, that will ensure that it is not an oblique section. So you should be able to see a proper skull, not a oblique view. Okay, so when you measure the biparietal diameter, remember it is a bone which has got a thickness, so it will have the inner margin and the outer margin. Okay, so when you put your calipers, so you should take from outer skull to the inner skull. Okay, so if this is the skull, you should take from outer aspect to the inner aspect. Okay, so you will have to leave the thickness on one side. Okay, so that is for the compensation for the thickness. Okay, this is a universally acceptable. So basically there is a near part of the skull and there is a far part of the skull. From the near part, you put your caliper on the outer edge, and for the far part of the skull, you put on the inner aspect of the skull. Okay, same plane is used for the head circumference also. For abdominal circumference, which plane is used? It is at the portal vein junction, and you have to take a circular section. Okay, so for abdominal circumference, portal vein junction plane is used. For femur length, beam should be perpendicular to the shaft. So this is one practical point you should remember. Now coming to the fetal anomaly scan, it is head to toe examination. So what are the points which we are going to see? In the head, we'll talk about the cerebellum, ventricle, cisterna magna, choroid plexus, CSP we will see, heart, four-chamber view, outflow tracts, abdomen, stomach, kidneys, bladder, umbilical cord insertion, spine, longitudinal as well as transverse views you have to look for, and limbs, all long bones. Okay, then we will talk about neural tube defect markers. So what are the neural tube defect markers? Banana sign, lemon sign, obliterated cisterna magna, hydrocephalus, ventriculomegaly more than 10 millimeters, and absent calvarium is suggestive of anencephaly. Okay, coming to the abdominal wall. In abdominal, there are two important defects, and you should know the difference between the two defects. There can be separate short note on this. Okay, so one is a gastrocystis and second is a omphalocele. Okay, also called as exomphalos. So you should know the difference between the gastrocystis and the omphalocele. The in gastrocystis, it is a right paraumbilical abdominal wall defect. There is no covering over the defect, while in omphalocele there is a covering. So amnion will be externally and peritoneum internally with water jelly between. Okay, so there will be covering for the structures which are protruding, while here there is no covering. So gastrocystis is a right paraumbilical abdominal wall defect, while omphalocele is a midline abdominal wall defect at the base of the umbilical cord. Contents in the gastrocystis are usually small bowel, occasionally stomach or colon may be seen, but mainly the small bowel. While here in omphalocele, you will get a small bowel, liver, stomach, and other abdominal viscera may have it. Okay, it will always have the covering. So covering is going to be very important differentiating structure between the gastrocystis and omphalocele. Another important point for gastrocystis, it has got a good prognosis and it is generally not associated with the chromosomal abnormalities, while omphalocele is associated with the chromosomal abnormalities. Prognosis is good with gastrocystis, while prognosis is not good with the omphalocele. Okay, so appearance is a bowel loops are floating freely in the amniotic fluid. Here you get a herniated organs which are enclosed within the membranous sac. Okay, umbilical cord, normal insertion adjacent to the defect. You can see here umbilical cord is inserted into the apex of the sac. Okay, then exposure to the amniotic fluid, bowel will be directly exposed to the amniotic fluid, while here herniated organs are protected by the sac. As I mentioned, chromosomal abnormalities are not very common with gastroschisis, but they are common with the omphalocele. Generally, trisomy 13, 18, 21 may be there. Associated congenital anomalies are not very common, while they are common with the omphalocele, especially cardiac, neural tube defects, Beckwith-Wiedemann syndrome, pentalogy of Cantrell, etc. These abnormalities may be present with the omphalocele. Then maternal serum AFP levels are markedly elevated. Here they are also elevated, but usually less than in gastroschisis. Okay, so free floating bowel outside the abdomen without a covering membrane. This particular feature is very specific about the gastroschisis. While in omphalocele, you will have a midline abdominal wall defect with a membrane covered sac containing the abdominal organs. Generally, good prognosis is seen with gastroschisis, while it is more guarded with omphalocele. It depends on associated anomalies and chromosomal abnormalities. Okay, so these two important things which you should remember. Then coming to the placental assessment, evaluate the site of the placenta, placenta previa, placental thickness you should mention, placenta accreta spectrum you should look for. Placental thickness at term is around 30 millimeter. Okay, if it is 45 millimeter or more, then it is an abnormal. Okay, you should also know the causes of placental megaly also. Then placenta previa, placental age more than 20 millimeter from the internal os, vaginal delivery is possible. Okay, in twin pregnancy, you need to find out the chorionicity. In diamniotic dichorionic twin, what you will see, twin peak or lambda sign you will be able to see, and membrane thickness will be more than 2 millimeter. Okay, then you should see about the umbilical cord, assess the number of vessels, single umbilical artery, cord insertion, filamentous insertion, vasa previa. Amniotic fluid assessment, polyhydramnios, AFI more than 20 centimeter or largest vertical pocket more than 8 centimeter. Then you will use the headlock formula for calculation of the fetal weight. Again, those four same parameters which we use for biometry, BPD, SC, AC, and FL. Error is around only 8 to 10%. Okay. Then there may be short note only on Doppler ultrasound. Okay, so color Doppler. If the blood flow is flowing towards the transducer, you will get the red color. If the blood is flowing away from the transducer, you will get the blue color. Okay, so a few important arteries which you will be describing. One is a uterine artery, second is umbilical artery, third is a middle cerebral artery, fourth is a venous like ductus venosus and all. So these are the four things which you are going to describe if you are asked about the Doppler ultrasound. You will mention write when do you get red color, when do you get blue color. Okay, and what is going to be the clinical implication of these findings. Okay, so first is uterine artery. If you get an early diastolic notch, that suggests a high resistance. If you see bilateral notch at 24 weeks, that means the patient is at risk of development of preeclampsia or fetal growth retardation. Okay, you look for umbilical artery. Normally, after 30 weeks, the S/D ratio is less than 3. Remember, uteroplacental circulation, the resistance falls down. So the S/D ratio is, so diastolic flow is quite good. So denominator is less, denominator is more. So S/D ratio will be less than 3 after 30 weeks. Okay, if you get absent endostolic flow, there will be poor prognosis, reversal of endostolic flow, very high fetal mortality. Then middle cerebral artery. In middle cerebral artery, if you see the increased diastolic flow, that means it is suggestive of brain sparing effect. Okay, so normally what happens, middle cerebral artery has got a it is a high resistance blood flow. But when there is a redistribution because of the FGR, in that particular case, the brain gets the, there is a vasodilatation and the brain will get a good blood supply. And that is why you get a increased diastolic flow in middle cerebral arteries. Okay, that suggests the fetal hypoxia or acidemia. Okay, this is because of the redistribution of the blood flow. Okay, more blood is flowing towards the fetal brain. Okay, then venous Doppler. Ductus venosus, inferior vena cava. If you see the abnormal waveform, that is suggestive of fetal cardiac dysfunction. Okay, important indices are S/D ratio, resistance index, and pulsatility index. Okay, so S/D RI and PI. These are the three Doppler indices are there. So what you see in the third trimester, objectives of the third trimester ultrasound. One is a repeat anatomical survey. Second, detect skeletal dysplasia such as achondroplasia, estimate fetal weight, assess fetal growth, assess placenta, assess Leica, and Doppler surveillance. Okay, so growth retardation, especially in what happens in asymmetrical IUGR, HC is preserved and AC is reduced. Okay, so what happens? HC upon AC, SC upon AC will be increased because AC is reduced, but the SC is preserved. Okay, what happens in symmetrical IUGR? SC as well as AC is reduced. So head circumference and abdominal circumference both are reduced. So SC upon AC ratio will be normal. Okay. Then ultrasound markers for chromosomal abnormalities. This is also very important from theory as well as practical point of view or viva point of view. You should remember for trisomy 21, it is an increased nuchal thickness, then cardiac defects, clinodactyly, short femur, duodenal atresia. Okay. Then trisomy 18, choroid plexus cyst, flexed overlapping fingers, very specific. If the fingers are flexed and overlapping, and rocker bottom foot, you think about trisomy 18. Okay, there is a emphalocele. This also we have discussed. Okay, cardiac defect. So trisomy 18, choroid plexus cyst, flexed overlapping fingers, rocker bottom foot, emphalocele, etc. Trisomy 13, holoporencephaly, cleft lip, cleft palate, polydactyly, renal anomalies, and echogenic bowel. Okay. Turner syndrome, there is increased nuchal thickness and hydros vitalis. Okay, so final summary. Uh, Ultrasound, Ian Donald introduced obstetric ultrasound in 1958. TVS frequency is 5 to 7 megahertz. Trans-abdomen is 3 to 5 megahertz. CRL is the most accurate parameter for first trimester dating. AC is the single most sensitive parameter for fetal growth. Transcerebral diameter accurately predicts gestational age between 14 to 28 weeks. The nuchal translucency more than 3 millimeters suggests chromosomal abnormality. Twin peak or lambda sign indicates dichorionic twins. Umbilical artery S by D less than 3 after 30 weeks is normal. MCA increased diastolic flow indicates brain sparing effect. So if you get increased diastolic flow in MCA, that is suggestive of brain sparing effect. Then you have a headlock formula, which is used for fetal weight estimation. Routine anomaly scan is performed between 18 to 20 weeks of gestation. Polyhydramnios, AFI more than 20 centimeter or deepest vertical pocket more than 8 centimeter. So that finishes the topic on obstetric ultrasound. Thank you.